Okay, let's talk about this really cool case of a triceps tendon rupture. This was a 40-year-old male weightlifter, which actually had nothing to do with why he was in the emergency department, I guess. But he presented with left elbow pain. He fell off an ATV just prior to arrival, and he had endorses pain and swelling in his left elbow. He didn't have any other injuries from the trauma. Well, it turns out he was using anabolic steroids. Maybe his weightlifting did matter. He had no other medical history. On physical exam, his vital signs are stable. Inspection of his left elbow shows significant swelling and ecchymosis over the posterior aspect of the arm here. And you can see that, right? This is impressively ecchymotic. You can't really see a deformity and very swollen as well. He was tender at the olecranon and distal triceps tendon, but really couldn't palpate a defect secondary to the amount of swelling. His range of motion was limited by pain to a 10 to 120 degrees, and strength was only 1 out of 5 in elbow extension. Let's talk about triceps tendon ruptures. They are pretty rare, right? Partial or complete. They're generally a very uncommon clinical condition, generally thought to be related to overuse tendinopathy of the triceps tendon. So there's usually some sort of preceding tendinitis that might set you up for the rupture. It is subsequently poorly studied in the literature, making diagnosis and management challenging, meaning that it's not well documented and there's not a real strong consensus about what to do for a lot of these cases. The tear most commonly occurs distally at the osteotendinous junction, as opposed to some other tears which tend to occur at the myotendinous junction. So that's a distinction. Most of the time, it is acute, either from falling, which is about half, or from bench pressing and weightlifting exercises, which is the other half. Our patient fell, but he was a weightlifter, so he kind of fits both of those buckets. And this is a picture of the anatomy of the triceps tendon, right? So this is a large three-headed muscle of the posterior arm, and it's the primary extender of the elbow, okay? The long head originates from the infraglenoid tubercle right here, and then the medial head from the posterior humerus and the lateral head from the posterior humerus, right? And then as these three muscles coalesce, they become one really thick tendon inserting onto the olecranon process of the ulna. On history and exam, you may get some type of insidious onset of gradual elbow pain related to exercise, suggesting some kind of tendinosis, or history of pain with extension movements at the elbow. They're usually tender at the distal triceps tendon, and of course, full tears, complete ruptures, they cannot actively extend the elbow. Okay. There's two physical exam findings that can be useful: the armbar test, which is where an extended pronated arm is subject to an anteriorly directed force. Okay. And then the Thompson test of the triceps. It's basically a squeeze test, right? So you squeeze the triceps tendon distally and you expect to be some kind of induced contraction. And of course, if there's a rupture, that will not move. Diagnosis is primarily made clinically. You have a high index of suspicion before you ever actually touch the patient, just based on what they told you and what you see. And then they're weak on physical exam, and so you're suspecting a rupture. But imaging is useful to confirm and exclude other things, right? X-ray may show an olecranon spur or an avulsion fragment. Ultrasound can clearly delineate the degree of partial or complete tear, but MRI provides the highest resolution and can also look for other soft tissue injuries. On the right here, we see a lateral x-ray at the top showing the so-called flake fracture here, where you see little bony fragments that are still inside of the triceps tendon that has ruptured. You also see this enthesopathy here, enthesopathy at the olecranon process, which is not necessarily directly correlated to the rupture. And you can see those in a lot of asymptomatic individuals who get elbow x-rays. On the bottom here is an ultrasound of the triceps tendon in short axis, right? So the tendon should be going across like this. This is the tip of the olecranon. And what you see is obviously a ruptured heterogeneous appearing tendon. There's blood everywhere, presumably blood, fluid, hypoechoic fluid. Okay, there's some cobblestoning here as well. And if we were looking at this dynamically, we could track the tendon more proximally distally and see the extent of the rupture, but it's fairly substantial. There's very few fibers intact on this view. Management is again difficult. There's not a lot of evidence-based management decisions made because this is a rare disease, right? So it's not really clear what to do, especially with partial tears. So there's a good study from the NFL where 6 out of 10 of the players fully recovered without surgery. That's pretty good. 3 of 10 ended up having delayed surgery, and only one of them who returned to play had a complete rupture within 6 weeks that subsequently required sort of urgent surgery. Complete tear are a different beast. Most people agree a complete tear is a surgical problem. You cannot really extend the elbow at all without your triceps, and so not repairing it is a problem. You can electively repair some of these partial tears that have more than 50% tendon involvement. The thinking is that those will progress to a full tear, and it makes the surgery more complicated. So our patient did well. He underwent surgical repair of a complete tendon rupture. His elbow was splinted at 20 degrees for about 5 days, and he began progressive passive and active range of motion, progressing to full active flexion and extension at about 6 weeks. He began light resistance training at about 3 months, 12 weeks, and last follow-up at a year, he had full strength and function. And this is a picture of our patient bringing his arm up overhead, and he is able to extend that fully, even though he's not quite there in this picture. So 3 key points, not portions. Triceps tendon ruptures are uncommon, with partial tears typically affecting the medial portion, and complete ruptures occurring at the osteotendinous junction, often following acute trauma or heavy resistance exercise. Symptoms include posterior elbow pain, weakness, and limited extension. Complete ruptures may prevent active extension entirely, and the diagnosis is primarily clinical, aided by physical exam tests and imaging to confirm the extent of the injury. Partial tears can potentially be treated conservatively with good recovery potential. Surgery is definitely indicated for complete ruptures, persistent symptoms, or significant tendon involvement. But again, there is no universal surgical threshold because of the rarity of this condition.